Good morning, everyone, and welcome to day 2 of Build 3.0. We will start today's day with a free chat on IR procedures in portal hypertension and HCC. We'll make this an interactive and informative session. Our moderator and speaker for this session will be Dr. Rahul Sheth, sir. And our chairpersons and panelists will be Professor Dominique Wala, Dr. Rishikesh Chaudhary, Dr. Mrudul Dharod, and Dr. Manish Dudhamani.
Should we just go down because the audio here is okay? Yeah. No, we'll just otherwise actually there's a lot of echo here. No? I was sitting there, couldn't hear anything on here.
Can you hear me, sir?
I can hear you. Can you hear me?
We can hear you, sir. Fine.
Okay. Yeah, please. So I think it's looking too formal an event, and there's only 5 of us here. But I think Akash had this brainchild of this thing to have a free chat, and I think since Dominic is here, it's mainly on portal hypertension and HCC. And in fact, we were just discussing with Dominic how things have. So Mridul, your question of how IR has progressed. In fact, that's an excellent question. We were just sitting with Dominic here, and I remember when I started off IR 24 years back, or 25 years back, and we used to basically doing a transjugular liver biopsy was such a big procedure for us. When we started off doing, I trained in KEM, I think Akash's place where he's working right now, my training was there. And we remember calling someone from outside to help us to do a transjugular liver biopsy 20 years back, 25 years back. Meaning it was a big thing because we were learning something, and now it's become such a routine procedure. So IR in portal hypertension, I have seen the era of doing splenoportograms. I have done SPGs where we have punctured the spleen, done a portal and venogram, seen the portal flow, measured the portal pressures for the surgeons, and that's all we used to do. Do the splenoportogram, refer it to the GI surgeon that time. They used to do the shunting surgeries, and honestly, I'll be very frank with you, I never understood a word of what was going on when I started off as a student. Then it came down to, then we reached the era of doing a jugular puncture, coming and doing the biopsies, hepatic venopressures. Then we did the first TIPS. When we did it, it was another big thing for us to do a TIPS. Like I was telling Dominic, I never understood TIPS as a procedure when I started off doing it. He doesn't like it too much. I never liked it when I did it first time. I said, this makes no sense to me. But connecting the liver to for the portal vein to the hepatic vein, and we're bypassing the liver, how is it helping the patient in any which way? My boss at that time also never liked the procedure, so we never did too many. I'll be very honest with you. So IR in at least portal hypertension now, from there to, I would say, in the last 10 years, at least in India, the last 10 to 12 years, I think it's more driven by the hepatologists, not so much by us. It is the change in your thought process which has changed the way we are thinking. I'll be very honest with you. The support given by the hepatic surgeons, and now transplant coming in a big way, and the transplant surgeons and the hepatologists who have said that this can be done and this should be done, and that has pushed us to innovate, work hard, and see how things can change. So, like, you take a simple, now we call it a simple procedure called TIPS. Now TIPS has become routine. Like literally Mridul will call me up at 3 in the evening and say, there's a patient have done a banding, it's not working too well, I need an urgent TIPS, can you do it by now? It's okay, done. When this used to be done 20 years back, we would have to think so much about it, how to arrange the material, how to get things, physically, mentally to get geared up to do a TIPS was, oh, thank you. To do it was a big thing for us. So the whole thing is now we can do a TIPS, and the way it has changed, like I was speaking to Dominic and he said the same thing. He said it works. The procedure works. It may not be physiologically correct, but it works. At least for the short term or the acute phase, it can get it off. And then with the new drugs and the way the thought process, how we are understanding portal hypertension better. I'm not saying we have still not understood it the way we can. Then we came to BRTO, another procedure where, honestly, I'm telling you, BRTO is a procedure where when we were training in KM, we never did a single procedure. We didn't have the concept of BRTO when I started off 25, 30 years back. It's when I came out when I worked by myself, when you attended meetings, you saw what people were doing, you read up, and then we understood the physiology of doing a BRTO. And I still feel that it's one of the most technically maybe simple, but physiology is one of the most difficult procedures to be done. I don't think we can satisfy anybody in a BRTO procedure. Although we are improving quality, like when I presented my papers as a session here, we started off by doing sclerosing agents over 24 hours, which we did such few because so impractical to do it. It was actually completely impractical procedure in a private setup in India, that you have to take the patient and then keep the patient in ICU for 24 hours and then get the patient back and check. It wasn't practical, so we never did too many. In the last 10 years, we've been doing so many BRTOs because, I think support from the hepatologists. Go ahead, do the procedure. In fact, now we're doing emergency BRTOs. I think we have done at least 3 or 4 in Reliance, where we have just gone in the for an emergency BRTO when the banding or the endoscopy does not work too well. And it's a procedure, again, which is being beneficial to quite a lot. And we are understanding shunt surgeries to a different level. I think, Dominic, you can add some, yeah.
Portal hypertension. So, can you comment on how the understanding of portal hypertension has changed in the last 3 decades, 4 decades, and where the role has now taken over by the IR?
The first thing I think we had learned a lot in pathophysiology and correction of pathophysiology with surgery, actually. But what we could not measure is the price in operative mortality and morbidity, but perioperative, and it was very heavy. And then we discovered that you were able to do virtually anything with the progresses, with the advances in techniques and expertise, probably, but still. And then we began to have ideas. Yeah, I agree with you. But the first step was that you were able to do things that we could not imagine. And to me, I think the first thing I've learned from interventions in portal hypertension is that going directly to the target is efficient. Sclerosing the varices, BRTO, etc., it is efficient, and it's not changing too much the physiology, which I am keen to. But then came the early tips. For me, it has been really, I had to change my mind. Before that, I was not convinced. There was no obvious increase in survival with tips, whatever the situation. But then, in this very short time for indication, it changed. And I don't know why, but although I am very, very interested by pathophysiology, I think the clinical facts are much more important.
Do you think that transplant has changed your thought process, liver transplant, going in such a big way? The way earlier transplant was a very, you have to really think about it a lot, and now it's being done literally like a
very good question.
A regular surgery. You think transplant has changed our thought process?
I think no, but if I was in India, I would say yes. Because we don't have living donor liver transplantation. We have to put the patient on the list and wait, and we cannot decide when to do the operation. This is the main difference, I believe, with living donor liver transplantation, when you can schedule the best time, the optimal time for the donor, but mainly for the recipient. And I think this has completely changed, to me, again, my mind. But you know, we have long been with enormous waiting list, with patients dying on the waiting list. Now the systems for allocation are more appropriate, so there is less incentive for living donor transplantation, because the the dramatic situations have disappeared. So that's it. But I think that transplantation has brought to surgeons a huge field to improve their expertise, and also to you, because you have played a big part.
Can you explain the difference between tips and dips? I mean, sometimes I'm seeing you're variably using those terms.
So actually, tips now, in my view, is if you look at all the data on tips, it is tips and dips should be same now, because majority of the times when I'm puncturing, technically I'm puncturing from the IVC itself. So dips is direct intrahepatic portosystemic shunt. It was devised for patients of Bacchiari when they didn't have any hepatic veins. But what they are claiming now is, earlier when we used to do the tips years back, we used to put it in the hepatic vein. If there's a patent hepatic vein, we used to put the stent in the hepatic vein. But now the recommendation is to put it anyway in the IVC, come what may, the stent. So dips and tips now is just a term we are using for the sake of using it. But all of us who are doing tips now basically puncture in from the IVC, just very close to the hepatic vein IVC ostium, and then we enter the portal vein, and the stents we are keeping in the just at the hepatic vein IVC ostium. Always we do it that way. What happened in India was that we used to work with the tip stent, the Viator, but Gore went out from there. So we have managed to, but still reinvent ourselves and use the same, we're reconstructing that same stent. So it helps quite a lot. Dips was used, the term was used only for, yeah.
My main question is, what is the limitation in recanalizing the portal vein in a patient with, I would say, cavernoma, not recent portal vein thrombus, but cavernoma? Is there a limit? Is it possible that you can, because you go from the bottom, that you are more able to recanalize even a vein that we thought had completely disappeared? Is it possible?
Good question. So when I get a case of a cavernoma, the first thing I have to study is the CT scan very well. The imaging has to be excellent for me to realize that, one, the intrahepatic portal veins are good, and there's an access for me, and if there is a communication. So where we can do it, let me tell you where we can do it. Where we can do it is if there is a communication of a narrowed vein, and then you have a good portal vein or a distal portal vein, then we are able to get a wire through, balloon it, put a stent, and extend the tip stent to a longer stent. Where we can't do it is if you have multiple small channels at the hilum. It's practically impossible. We may be able to enter that, but sometimes if it's a tortuous, like a varicosity type of a thing, it is impossible for us to do. There's a limitation there. It's not that we can do everything. I wish we could do everything. But if it's a nice long collateral, so we have done tips, a couple of cases of ours also, where we have seen, we entered on this imaging, we saw that there was a huge collateral which was behaving like a portal vein. So we have done it to that, and it has worked. But those are far and few in between. But if you're looking at those cavernomas which have multiple small collaterals all the way at the hilum, those may be impossible to canalize. If we can see a small channel, we'll be able to do it. Because we have the beauty of having covered stents now. So we are not worried about rupturing the vein or tearing the vein. Tomorrow, God forbid, it does happen, we can immediately put a covered stent and close that channel and be safe.
And do you see a possibility to, in some patients, other patients where you could do a Rex shunt? Do you see what I mean by a Rex shunt? The shunt that the pediatric surgeons do for cavernoma between the superior mesenteric vein and the Rex recessus, or the left branch of the portal vein. And then they have wonderful results. I don't know why, because, well, they are wonderful results, I think, because they are, again, respecting the anatomy of
like the paraumbilical vein. So I have not done it. I'll be honest with you. I have never done this procedure going in from the left portal vein into the cavernoma type of a thing. I don't think we have seen a case. I have not seen a case till like that.
Mostly pediatric.
Yeah.
And we have done tips from the left portal vein when the right portal vein was blocked.
Yes,
another tip
yes.
was
We
blocked.
have done a left portal vein tips. We have used we have punctured in from the hepatic vein into the left portal vein and entered into this thing where the right was not, it was not doing too well. And right was very, very narrow. It was impossible. So we have that. Accessing the left portal vein now is not that difficult. Actually, sometimes, a lot of times we hit the left portal vein when we're doing the tips anyway, depending on the anatomy. It all depends on the liver anatomy, how the liver is based. So a lot of times we hit and it's a safe, in fact, the angle is much better, and I feel sometimes in some cases the patency is better than going in from the right side.
Rishikesh, you work in a tier 2 city. So the challenges that you face to get an IR involved in case you need one, it's not easily available.
No, it is not easily available.
Yeah.
And the first part is we have to counsel the patient a lot and
Yeah.
referring a patient to a tertiary care center and knowing about the expertise of particular IR is quite a big problem for us.
I'm sorry, where do you work? Where?
Gurgaon.
Okay, Jalgaon.
So then what would be the selective cases probably in your practice you want to refer to an IR?
Like mainly TGLBs, then BRTOs, then in like tips for refractory ascites. Because transplant is again impossible there in two-tier cities for many reasons, like from financials to donors and availability of donors. So for refractory ascites, we generally refer for tips.
Okay. So one question for you. I mean, I was just going through a couple of our cases and in detail and everything. You have used like the covered stent and the open stent also. So the role of the covered and the uncovered stents.
So see, when you're doing tips, you're going through the liver parenchyma. The minute you go through the liver parenchyma, earlier the first tips they used to put a bare stent.
Yeah.
When they put the bare stent, they realized that there used to be a lot of ingrowth into that stent because and you would be hitting small vessels. You'd have tissue ingrowth into the stents. Then came I think the game changer was the covered stent which came in, where the stent with the graft covering around it. So what that does is protect the tract. It sort of limits the ingrowth which can come in from the liver tissue into the stent. Two is that if you have even hit small vessels in that, it closes off those. So you have not damaged, you're not causing any torrential bleeding because we're doing it for refractory ascites. Majority of the times, quite a few of the times, you're doing it for refractory ascites. And these big stents, they say the patency of a covered stent in a tips is slightly better than a plain bare stent. But the covered stents all over the world don't have that radial strength which are there. So you have to have the original tip stent, if you see, the made by Gore, the Viator, he's got a 2 centimeter bare stent which goes into the portal vein, in the right branch of the portal vein. That keeps the flow patent to the normal liver flow also. You don't want to completely close the flow to the liver. So you keep that bare stent there, and then you have the covered stent in the tract, which goes into the hepatic vein and the IVC ostium. That's how the stent was designed. But for some reason, Gore, the Viatograph company, Gore withdrew from Asia. We don't know why, but they withdrew from Asia. And then we decided to make our own sort of, everybody in the world who didn't have this thing said, use the same principle. So we keep 2 centimeters of a bare stent in the portal vein, and then we cover it with, we keep that in the IVC, and then in that we put the covered stent from the portal vein ostium, and then extend that stent from inside and keep it. So covered stent is mandatory in a tips. Bare stent tips is as good as not doing a tips, in my opinion.
You're putting in a bare stent and then you're putting in a covered
First,
stent.
we put the covered stent from the portal vein, just where you puncture the portal vein. From there, the covered stent starts, goes into the IVC or the hepatic vein IVC ostium. And then through that, now we are putting in the bare stent into the portal vein. With the standard tips stents, you don't need to do that. It comes as one, it comes like that, 2 centimeter bare stent and a covered stent outside. So it makes life very easy for us.
I had a very specific question. From the complications of percutaneous liver biopsy, I draw the idea that what is the only cause of portal vein or hepatic vein thrombosis following liver biopsy is bile duct injury. Yes. And bile coming into the. Is it true also? And is it a part of the efficacy of the covered stent?
Yes, yes. The main
Blocks
thing it
the
was
bile.
because of bile leaking into the.
Yeah.
So there are times when you do a tips and it's Murphy's law. When you're doing a PTBD, you will hit the portal vein. Always. It always happens. When you do a tips, you will hit the bile duct sometimes. It's it's all, I don't know why. It's when I'm doing a portal vein embolization, I will get the bile duct. First shot, I'll get the bile duct.
They are close one to the other.
Yeah, but it is hilarious. It's become a joke now for me. Like, so I said now I should think that I'm doing a PTBD when I'm doing a portal vein embolization, and when I'm doing a portal PTBD, I should think I'm doing a portal vein embolization. It's hilarious. I always land up. It's just whenever you're doing it, majority of the time that's what happens, and it's really funny. But the covered stents really prevent that. It prevents bile leak. It prevents leak from even, suppose you have hit a small hepatic venous branch which is oozing. It stops that also. But the main thing what Dominic said rightly is, I should have said it, is it's bile leak. It prevents bile leak, and bile is very good when it's in the biliary system. Bile outside the biliary system is a disaster. So it can just cause, we all know that, right? We have all experienced that. So it's just a terrible, terrible thing to have, and the covered stents are really beneficial in that. They really help. I think TIPS had a bad name because TIPS years back, when it started off, was done with bare stenting. Hence, I think the TIPS never took off in the initial phase of it going off. And then when they did the studies and they realized what was the problem, and when technology improved, covered stents came into the world. Things changed in TIPS, and it's now reached a stage where it has become an accepted procedure. I remember we didn't have great covered stents at that time. The quality were not good. They used to collapse, they used to fracture, and they would not do too well. But now with the quality of covered stents coming in, things have really dramatically changed.
You were asking something.
Regarding TIPS, sir, is portopulmonary hypertension is contraindication for doing TIPS?
Pulmonary hypertension?
Portopulmonary.
I didn't get that.
Pulmonary hypertension, I think it's an absolute contraindication.
Yeah, so in TIPS, pulmonary hypertension is a contraindication. Diastolic dysfunction, not a good heart. Low EF is not something which I would want to. So there are, TIPS has to be well selected, especially elective TIPS. You should be very, very careful in what we are selecting. We have burnt our fingers quite a lot where we felt TIPS would work in the patient. Your cardiac evaluation has to also be very good. So in this case, you don't need a good interventional cardiologist. You actually need a very good clinical cardiologist who does good 2D echoes to see if the diastolic dysfunction is bad. I would be very hesitant to do a TIPS in those patients, because you may get an excellent technical result, but a lot of the patients, some of the patients can have a very bad outcome. So a selection of patient is mandatory.
Dominic, you will just elaborate on this cardiac evaluation prior to.
Yeah, I think it'd be good to get from you.
We have learned that it is important. I think that the diastolic dysfunction was not, we knew it, but we were not convinced until the problems with the TIPS.
Yes, yes.
Revealed actually the problem of the diastolic dysfunction. And then, but now I think they have good rules. There are good algorithms to select the patients for TIPS. But it's more diastolic dysfunction than portopulmonary hypertension. I don't know this area very well, but I think that it can be very dangerous. So I think what is not a contraindication is the hepatopulmonary syndrome. This is not it is not a contraindication, but it's not an indication either. It has no good, especially good impact. But portopulmonary hypertension, I would ask the cardiologist.
And as per my knowledge, pulmonary hypertension, I guess, less than 35 mm of Hg is not a contraindication.
Not a contraindication.
35 to 45 is relative, and more than 45 is absolute.
Severe pulmonary hypertension, anyway, the patient honestly would be too sick to go in for a TIPS anyway, more than 50, 60. patient would have many more issues than tips to do it. But yeah, it's mild pulmonary hypertension because again the quality of drugs to treat that mild pulmonary hypertension have dramatically changed. We didn't have those 15, 20 years back. Now you speak to a chest physician. So the beauty of IR is one thing which I like, is that I get to meet every specialty and talk to them. No, it is a fact. It really helps our thought process, that where we can apply our knowledge from that branch, and we can use it, because we are combining the GI to the lungs. You know, technically you are combining portal vein straight to the to the pulmonary artery, pulmonary pressures. So it is something where we sit with chest physicians and realize what is going on. It makes a big difference.
One question, during putting tips, diameter of the stent, 8 mm versus 10 mm, how you decide and where you do it?
So that's a excellent question. When we started out doing tips, we used to use always a 10 mm. It became a mandatory, because I think the results which happened with the 10 mm were dramatic. You know, ascites going off in 48 hours, patients doing well, bleeding stopping. But then over years, we realized the hepatic encephalopathy with 10 mm stents was very high, extremely high. We were seeing patients coming back after maybe 2 to 3 weeks, 4 weeks, with bad HE, not doing too well, and then that literally negated the benefit of tips. So all the good you did, the patient's quality of life was miserable. So then I think the studies came out that an 8 mm stent is, again, not the, you still will get HE in some patients, I'm not denying it, but manageable, and sometimes you will get, few cases will always be which will, but the 8 mm is now become the standard of using it to give a good result from the tips point of view, and also try and prevent the HE complications. Again, so when we used to use a 10 mm, there used to be a lot of procedures to reduce the HE, to reduce the size of the tips used to be done. Now I think because of the 8 mm, that has been sort of abandoned. We are not doing any, trying to reduce the size of the tips by putting a smaller stent, you know, bridging, making it 10 to 8. Now you can't do that to that stent. You put in another stent. You have to, in the middle, you have to make it narrow. All those things which makes the procedure very poor. So 8 is helping quite a lot.
I think I've seen recommendations for ascites, beginning with a small shunt, very small, and increasing it if it is not,
if necessary.
I like that. Like beginning small and growing if needed.
So we have started doing, sir, in some of those sick patients, not just put in a 6 mm.
6 mm shunt,
For the next few days.
Yes.
Then if required, it goes in and does increase it to 8 mm. Dilated.
Like that.
So the stents, if you're using, so the beauty is, if you're using a 6 mm stent, nowadays you can't increase it to 8. So what we do is, we put in, we'll balloon the tract only with a 6 mm, put in an 8 mm stent there, but it'll open up only to 6. Then if you tell me later on, I want to now make it 8, I can just dilate that to 8 mm. Because balloon, so in IR, we have something called balloon mounted stents, which can expand to even 6 mm can become even an 8 mm, 10 mm if we want to do that. But we can't use that in the tips because they're too stiff. They're too stiff to take that curve. So we normally use this. So this is how we are in. So again, what I was telling now, the innovations which we are learning ourselves, what we can do with our products is amazing. And for that, we have to thank even the research by all the companies which they do and give us these products for us to use, because it's unbelievable what we are using. For example, when I presented here, we're doing BRTOs now. Now, BRTOs was a challenge because of material, I'll be honest with you. Why sclerosing agents at one stage? Because there was nothing else left to sclerose. Then came glue, simple glue, which you use a lot for your so we mix glue with, you use direct glue, if I'm not mistaken, right? We use glue mixed with lipiodol when it's in the vascular system. And that helps us to change the percentage of what we are injecting. So if I feel that too many varices, I need the glue to dissipate all the way inside, we can alter our percentage, our strength of the glue. So if you either have 20%, 30%, 50%, we can do it and it can dissipate better. So 20% will go in further and we can inject more of it and go. Then it came to using coils. So earlier we used to have only coils which were pushable coils, where you should push it in and that's it. You couldn't do anything. If it flew somewhere, it flew. Then you go and retrieve it. Now we've got detachable coils coming in sizes of 24 millimeters. Imagine 24 millimeter coil going through a micro catheter which is less than a millimeter in size. So 24 millimeter coil, and it's a detachable coil. So I can push it in. Am I happy with the position? Looks good. And then release the coil. I'm not happy, I can take the coil out and reinsert it again. That is borrowed from the neuro coils. Now they've come even in this. So then came plugs. So plugs again borrowed from the cardiologists, where they use it for their devices for ASDs and closing patent duct and arteriosus. Now we are using it for our products also. So that's where the word pato came in. You know, so technology has helped us do a lot of things, and simpler and easier. If imagine putting in a 10 millimeter stent in a tips in a liver through a small 3 millimeter sheath. Technically, the size of the sheath is less than 3 millimeters. So that's what we are doing, and that's amazing how technology has helped us.
The part of this talk was portal hypertension and HCC and the role of iron. So now we'll come to that.
CC, okay.
With the presence of, say, a large right lobe HCC, and I refer to you for tips.
For tips.
For tips.
Oh.
So there's a tumor. So we'll take two scenarios. There is a tumor with no main portal vein or thrombosis, but there is significant portal hypertension, and I have referred to you for tips. And there's another with the HCC, but with the portal vein thrombosis, and again a refractory portal hypertension, maybe recurrent bleeds or an ascites. We have done a few cases. So
That's a,
yeah.
HCC, in tips in HCC, again, it is only your team which has changed my thought process. I'll be very frank with you. We used to never do it because we used to always worry that are we going to go through the tumor and hit in the portal vein, and then you're basically either disseminating the lesion around. But again, imaging, quality of imaging changes our whole thought process. When we see the image and we realize that the HCC is not in my path of the tips, then it's extreme. Then it's like doing a normal tips. Now the worry is if it's a central HCC sitting at exactly where you're entering, then either we try and find a vein which is far away from it. At times you may still go through the tumor. Again, the covered stents will help from tumor ingrowth into your thing, but we are not sure the long term of that. And we can still do it. So there will be certain cases where if it is bang sitting on the portal vein, maybe it's tough to do a tips because you'll be literally going through a large area of tumor. Coming to your second point of view with portal vein thrombosis, if it's a tumor thrombus, then we are worried. I'll be very frank with you. Because tumor thrombosis are hard, they're difficult to do anything to, and then we don't even know whether we are properly inside the portal vein. If it's a bland thrombus and we have entered in from a normal, that's something which we can do easily. We can aspirate the clot out or even balloon that area, fragment the clot, and then put a stent across it and do it. So in HCC, again, imaging makes a very big difference to us to see location. One, is it a bland or a tumor thrombus per se? And then we'll modify our procedures accordingly.
Does your literature mention doing tips through the tumor?
It's all anecdotal. I mean, there is no much data on that. I mean, I've not read much. I tried to go through it because when you guys told me to do the first case, I was like, with HCC. And Akash said, no, do it. I said, okay. So then I don't like to just do something. I'll go and read about it for some time. And then there are a few cases and exactly what, but I don't think you can ever have a comparative study of HCC. There's not that many cases where you'll refer to us for a tips any which way.
One of my concern is with spreading tumors.
That's
in
biggest
the
concern.
lung.
Biggest concern. Because if you have, so especially those tumor thrombosis in the portal vein, very difficult, because that means you're giving us nice channel for it to go to create a metastasis to the lungs.
Yes, because I don't like the word tumor thrombus. I prefer invasion or.
Okay, sorry. Okay.
For me, a thrombus is platelets and fibrins and.
Okay.
You would still
Anyway,
call it
but
as.
no, but no. What I mean is that the tumor in the portal vein, no problem because there is the liver
Yes.
to as an umbrella. But in the hepatic veins, in my experience, most of the patients with invasion of the hepatic veins have lung.
Yes,
metastasis.
lung metastasis.
So it's why I have a concern with,
Needling that area.
Yeah.
100%.
unless of course there is a very efficient treatment, pharmacotherapy like immuno, but otherwise I think I would prefer not to.
I'm with you on that completely. So, I mean, you have to study the anatomy. If it's, let's say, a segment 8 lesion sitting far away from your place, there is no hepatic vein involvement on, then it's like doing a normal tips, or a segment 5 sitting deep inside down. It's the central ones which I would really hesitate to do a tips on, more because of seedling the thing all over there. Then I don't think we've achieved anything.
So then, sir, why has the definition not changed? We still call it VPT and it PVTT, portal vein tumor thrombus. It should be TTT, tumoral invasion, TIV.
It's very difficult to name things,
Yeah.
in medicine. We have done a lot of errors. Although we try to give good names, but still. And then if the word is used and there is no misunderstanding, okay. But I know of people that would use thrombolysis for a tumor thrombus. Yeah. Just because it's throm.
Yeah.
And then
Actually, it's fibrinolysis. If you want to be very specific, it's fibrinolysis. It's not thrombolysis.
No, but
Yeah.
it's a joke. But so I would prefer invasion.
Yeah.
Invasion or intraportal tumor, extension into the portal vein or whatever you say. You don't say, for example, you don't say it can extend in the bile ducts. You don't say a bile thrombus or.
Yes. Would all HCCs have a capsule? HCCs have a capsule?
No, I think that.
Not necessarily.
I can't answer you. I think that there is a pseudo capsule, and when of parenchyma, which is compressed, and when this is invaded, it's a poor prognosis. But a true capsule, a true membrane, I don't know. I doubt.
Because I was just wondering how will the tumor invade the portal vein, if it has a
Well, I
capsule.
think it invades, growing into the very small portal radicals and then
It
extending.
moves in. Yeah, it moves in. It moves in.
Yeah.
So regarding the ablation of SCC, we have read about many methods: RFA, microwave,
Cryo.
cryo, high voltage, some
IRE has also
IRE.
come. Yeah, irreversible
Which is better?
electrophoration.
Which one is better?
Okay, good question. I always get asked this question: which is better? Why can't we use this? Each one has its own methods. I don't think this is the forum to discuss the physics of RFA and microwave. But the basic thing is ablation. So in ablation is we are looking at the veins and you're looking at the location of the tumor. I mean, two things we look at when we're doing an ablation. If there is a vessel close to the tumor, we are very worried of ablating it with radiofrequency because there's something called a heat sink effect, where you're burning the lesion, but because the vessel is very close to it, it's literally taking the heat and transporting, so you're not getting an adequate burn. Because RFA requires a little longer time to burn. Then came in this microwave ablation. So basically, like using the technology of microwave cooking, where it basically cooks it very fast. How we have a microwave? Earlier cooking was in an oven. So RFA is like your oven. You cook it 25 minutes, 30 minutes, you're cooking something. The times have changed. None of us are, people don't have 25 minutes to spare. So microwave came in where in 2 minutes flash burn. That is where microwave is used to do a flash burn. So it just, it uses the technology and just kills the lesion very fast. So our microwave burning is less than 5 minutes, 6 minutes. That's it. You don't require to burn for more than longer time because the heat generated is so high and the chances of heat sink are very low. That also uses, then you can use it in cases where they're subcapsular, very close to viscous organ, where you use microwave ablation. Then came cryoablation. Cryoablation has been there for a long time. It has just recently come into India as a different issue. It's been there in the world for a very long time. In fact, in France, I think one of the IRs does so, I forget his name, but he only does cryoablations. He has that much work. And they do it, it started off by doing it mainly for kidney tumors and inoperable RCCs. So the principle of that is to form an ice ball and kill. Basically, the principle of all this is to call cell apoptosis, to kill the tumor. That's it, nothing else. So every technology has its pros and cons. There's nothing better or not. We use more of microwave now because it's good burn. And now also practically in India, the cost of microwave and RF ablation is not that much change. Earlier, RF used to be much cheaper than a microwave ablation, but more microwaves being done, more companies coming in, the cost of microwave ablation has genuinely come down. It's maybe 5,000-10,000 rupees more in Indian rupees more than an RF. So then why would I not use that technology?
That means you meant to say that there is no heat sink effect in microwave.
No heat sink. That's why you can use it close to a vessel and you can use it close to a capsule.
What about tumor size?
Again, tumor size started off with 3 centimeters. Now we have gone to 5 centimeters.
With microwave.
Yes.
With RF and microwave, the things remain the same. In fact, say with cryoablation, you can even use bigger tumors and use more of the needles to create an ice ball. Even in microwave, we can go up to 7 centimeters. You can burn one area and then use another needle and burn the other area. So you can do it without, we have done it up to, but I would say up to 7 would be maximum in certain cases where it's a single lesion. If it's multiple lesions, maximum would be, they say 5. Maybe it's now 5, you can always say 1/6 came in, you can do it. But it does get, but I think 5 is the limit where we go to. So maximum I have done is 5, not gone below more than that.
Even
But again, small lesions less than 3 centimeters, 5. 5 lesions more than 5 centimeters, I would not do. I'll be very frank.
with RFA, you can go up to 5 centimeters.
Yes. RFA can go up.
Somewhere I was just reading the comparison that MWA microwave can go up for a larger lesions and the smaller lesions you
In
can.
RFA, you can go up to 5 centimeters. But again, remember the time of burning then goes to nearly 40 minutes.
Okay.
So it can create a lot of complications. That's why microwave is better
For the larger tumors.
For sure, it's a short burn.
How was your experience for the TACE in HCC? Because couple of patients I saw in Tata, they underwent 7 session, 8 session, and they very well maintained.
Again, the concept of TACE, honestly, I have learnt all my concepts of TACE now from the Japanese and the Koreans. I think they are the masters in TACE. I think everybody in the world will agree that the way they do it, at least again, maybe my personal opinion, what we used to do TACE when I started out doing TACE was, I would think rubbish how I used to do it. When I went to train and spend some time with the Koreans, and they do super selective TACE to a different level. Means they don't, we used to just go to the artery, see a tumor. Also because when we used to see lesions that time, we used to see large lesions. When I started out doing TACE 20 years back, we used to see 15 centimeters, 20 centimeter HCCs. We don't see those HCCs anymore. Why? Again, surveillance has become better, medicines have become better, people are coming in much earlier, pickups, imaging has become better, CT scans, MRIs, PET scans have picked up lesions which you may not have reported also. So now we are not seeing those 15 centimeters. I don't think, do you see?
We are seeing, but we are not referring for TACE to you. That is another aspect.
But again, if you see,
yes, so
it's become much lesser.
much lesser because we are more often doing the AFPs, the sonographies.
Exactly.
Imaging has become more.
Imaging, so you are seeing,
Unless-
you will still see from a village, poor guy is still going to come with a 15 centimeter lesion. But I'm saying it has become much, much lesser.
Yeah.
So then now if you're having just a 3 centimeter or a 5 centimeter lesion, I cannot go in and ablate a large segment of the liver. So where taste has changed is purely has changed on technology. I'll be very frank with you. Because when you're doing a taste now, how we do a taste is, that is how I do a taste is, inject through and we do a CT run with our machines. We have a CT machine, Dyna CT in our scan. We do the taste, we see the exact branch, 2, 3 branches going there. And with our microcatheters now, we can go up to the subsegmental, I would say the deep intrahepatic branches and just embolize that much small part. So I remember starting off by taste by using 50 milligrams of doxorubicin, 50 milligrams of cisplatin with 10 ml of lipiodol. Now we barely use more than 4 milligrams of doxo or cisplatin with maybe 1 ml of lipiodol, and we embolize it with the particles we have. And now we've got DC beads, which we're using, drug-eluting beads, which come up to 50 microns, 100 microns. So we can go all the way deep and only ablate the tumor and the surrounding part of it a little to give it. And so that's why it has, all the tastes which we are doing are super selective tastes. We do not do sub-selective tastes anymore.
So we have started doing tests for even 3 centimeter lesions.
3, I have done for 1.5 centimeter.
Here, how would you choose between the MWA and TACE?
Location. So only difference, if it is 3 centimeter lesions and if it's amenably, everything is good, if the ascites is not too bad. See, small sliver of ascites, MWA is still okay. But if you got a big perihepatic fluid collection around, I would not like to ablate anything because it can cause a massive complication. Again, if it's a deep sitting up segment 8 lesion, very close to the diaphragm, impossible to access with the needle is too high, and or the lung is, because the lung comes through that, then again TACE would be used in that. So, but if it's very close to the central lesion, sitting bang at the porta, to access it means going through the portal vein, some branches, major branches, again I would not do an MWA. But if it's location wise, if it's an amenable lesion for MWA or RFA, I would do for a 3 centimeter lesion, I would always like to do it ablation. If it's not possible, then TACE.
And post-test, sir, after 6 weeks or after 12 weeks, what do you recommend, CT versus MRI? Like always confusing.
I am more of an MRI person because I think MRI it picks up lesions much better. Again, MRI, it is in our center, MRIs being done are done properly for liver because there's so much volume of work coming through them. A lot of people who do MRI don't know what they're looking for and how to do the MRI. So I'm not a diagnostic guy at all, but there's so many sequences for HCC which you need to do to pick up as one, your response, because your reporting of the response is very important. Like for example, when I do a tear for a lesion, a lot of times people will report there is peripheral enhancement, means it's active. They report it like that. Now, I'm doing a tear in Bombay and your patient, and it comes back to you, your radiologist reports that it's active, you'll say the failure of procedure immediately. It's not. Peripheral enhancement in a tear is part of the procedure. Yeah, it is how the lesion will look. So it is how the MRI is done, how the reporting is done. And a lot of people, like now RECIST criteria, modified RECIST has changed. But all of us used to go by size of the lesion. Why the tumor hasn't shrunk? Why a 7 centimeter hasn't shrunk to 3 centimeters? It's not the size anymore which I look at. I look at activity, the washout. If there's no enhancement, there is no washout at all, means you have done a successful procedure. So you have to sit with your radiologist and discuss with them and tell them that you have to report in such a way that will help. Because tomorrow all your decisions are based on that. Whether if my taste hasn't worked, you have to switch to the next therapy.
Yes,
But
that
if-
is the common problem we face in peripheral settings.
Yeah.
They always say that there is an enhancement of ring.
Yeah, the ring enhancement is normal.
And how to distinguish between a dead tissue or inflammatory or active?
That's why MRI is the
Central necrosis, they can actually see the central necrosis.
Central
MRI
diagnosis will be there.
You will see an ADC drop. So there's something called diffusion coefficient. If the diffusion coefficient is too low, then you're looking at it's an active lesion. If it is very high, means it has no activity. So that is what, again, I'm purely an intervention guy. So my reading of MRI is based only like all of you now, because the sequences have changed so much in 20 years. It's impossible for us to keep up with what, but because we're radiologists, we know how to read it and we talk to our colleagues. So they say that an MR imaging for a tumor, there are very few good people in the world who know how to read a good MRI. That's the thing. Machine, yeah. So a 3 Tesla versus a 1.5 Tesla makes a big difference. Plus the person seeing it makes a big difference, and how many sequences it takes. So I think that close to 16 or 17 sequences for a good MRI abdomen to do a proper follow-up.
Ma'am, would you like to comment anything, please?
Come, ma'am.
Come in. Prabha ma'am, she has been HOD of Sion Hospital, now at a global, yeah.
Have you done TASE even if the HCC fits in Milan criteria?
So, ma'am, all our cases, frankly, will be now, all our cases are ma'am, please say, please. All our cases are frankly discussed very, very in detail with, yeah, it's not that Mridul will send me a case and say, just do the case. It will be a discussion of why, where, and if for some reason the patient doesn't have the wherewithal to do the transplantation and cannot go ahead with doing it, then we can still, to buy time, we can do the case. But nowadays,
If you have done, even if it's fitting in Milan criteria, how have the patients done?
but if they're fitting in Milan criteria means they're fit for the transplant, right?
Yeah.
That's what you're saying.
Yes. Have you done, I'm asking if patient is reluctant for a transplant and has he come to you for
Yes,
TASE?
yes.
And
They've done very well.
How were the results like?
Very good. In fact, there are few patients, at least I can count now 6 or 7 in the last 1 year, who I have said, please go in for the resection.
Mhm.
But for some reason, there's a reluctance even to do a resective surgery. I think Akash will know the names of the patient, and they came to me for a TASE, somehow directly for a TASE. Very rarely patients come directly to an IR for a TASE. They came to me directly for a TASE, and I sent it back to Akash and said, this looks eminently either resectable or going in for a transplantation. Eminently resectable, I felt. And one gentleman was more fit in your Milan criteria, but the patient just refused.
So I would just answer to that.
So we have done and very good results.
Yeah. So some patients would respond well. We have had a couple of patients where like we have to do 2 or 3 interventions in terms of RFA, MWA or TASE, and still new tumors are propping up every now and then. We have been advising those patients transplant for almost 1.5 years, if you remember that one lady. So so either new tumors propping up, or sometimes at some point of time, even post TASE, some tumors just don't go away. Just don't go away. So it's
That's always going to happen.
Because post-transplant also I've seen some of these anastomotic strictures.
Oh, they're terrible.
They're terrible, and patients have to spend so many hours, and it's like, and I was impressed by your saying that you do super selective
Yeah, ma'am.
TASE, and
We are now only doing super selective TASE. At least in our setup, we are only doing super selective TASE.
There is something which I don't understand very well. It's now what is the place of radio embolization versus TASE? How do you choose?
Okay. Yeah. So
it's not clear at all.
Yeah. So one is, we have to try and change the word radio embolization. I'm very against that word, because so TASE is transarterial chemoembolization, where we are giving the drug and then we are blocking the blood supply to the tumor by using special particles. The disadvantage of that is to cause hypoxia, and that could stimulate the growth factors and sometimes actually make the tumor grow faster. Secondly, you're blocking the blood supply to that area. Sometimes even the normal liver tissue gets, so it used to change the liver functions of it. Then came in internal radiation therapy, which is SIRT. I'd like to use the word SIRT, selective internal radiation therapy. The reason is, those beads which we're injecting are very, very extremely small. They come up to 5 to 10 or sometimes even 20. Maximum size is 100 microns, maximum, the range. That's one. Two is, they are not embolizing any, we are not blocking any blood supply. So the ischemic complications of embolizations are not there. Two is that the other thing, because they are they're such small particles, it can also radiate the tumor and also open up the portal vein. If you have portal vein thrombosis, because main portal vein thrombosis is a contraindication for doing a TACE, right? So nowadays, segmental portal vein thrombosis is not a contraindication for doing TACE, but main portal vein thrombosis is a contraindication for doing TACE. And there, the only option was using this, because here it does not block the blood supply, and the radiation at times is known to even partially open the portal vein invasion. I will not use the word thrombus since you don't like it. Portal word invasion, it reduces the invasion of thing, and that's where we are using radioembolization. Now, CERT. Where CERT is now playing a role is, it has also been shown, I don't know, we have seen few cases, we don't have such a wide experience. I've done quite a few cases, but not compared to what Riyadh and all have done in the US. But they also, when you you can embolize a large area of the liver, inject a large area of the drug into the liver, and it also promotes contralateral hypertrophy. So in some patients, it is also known to you can prevent doing a portal vein embolization, segmentectomy or lobectomy, and it's being used and it's being done well. And the side effects of CERT are little lesser than TACE.
But what about the shunting?
Yes. So CERT is the most important procedure. I look at it in CERT is the planning. You have to do a good planning. So one is, again, imaging. Second is, we do the technetium 99 MAA planning scan, always done prior to injecting this, where we inject technetium 99 MAA, microalbumin aggregate, into the tumor, and then we send the patient for a SPECT scan, see the liver to lung shunting, also the liver to gastric, if there's any uptake by the gastric mucosa, because you don't want that beads to go either in the lung, too much of it, or nothing going into the gastric area. I have one patient who was referred to me by someone else who had done this CERT, and they didn't coil those branches, and that patient had a superb technical response, but he had the most miserable existence after that, because he got gastric ulcers, and it was a miserable period. So, and he died because of those gastric erosions. So, CERT has to be planned very well. You have to look at the uptake. And the advantages I feel of, in my opinion, of technetium is, it tells you whether the tumor is taking it up, the technetium. If there is a high background activity, more liver activity with the technetium 99 and not much in the tumor, then it's better not to do the procedure. Then it's better to say, this is not suitable for CERT, let's go in for other therapies.
It also allows you to compute exactly the
Yes. It lets us know how much the lung shunting we calculate. It lets us know, and then we do something called a CT volumetry immediately when we know it's possible, and then we calculate the exact amount of dose which is required. So calculation of the dose of Y90 is extremely mathematical. You need to get the CT volumetry, you need to know the liver to lung shunting. In some formulas, you need to know the body weight of the patient and the surface.
It makes the procedure more complicated, and
not anymore. Maybe the first 10 cases when you start doing it is a little overwhelming, but now it's, because we're doing so many, so we are pretty used to it. It makes it more complicated in the sense that it makes it a little demanding for the patient, that he has to come twice. Once for the angiography, then do the scan, and then second time, then for the injection phase, which is the second part of it. But now, the companies have decided that if you're confident, they will keep the dose ready, and you can do the planning stage. If it's suitable, the same time after 1 hour, because the planning takes you 25 minutes to get it done. So that's how, again, technology is changing. So I can do in certain cases, not all till now, I can do a CERT in the same day, if required.
We're nearing end of this chat. Anyone from the audience would like to ask anything regarding the any intervention procedures for the IR or for the HCCs, anything? Anyone has any comments or anything?
Sir, apart from SCC, what is your experience about solitary liver metastasis in colorectal malignancy?
Good one. So those surprisingly so CERT was started off mainly in in certain countries for colorectal metastasis, not for HCC. In India, the referral pattern from the oncologist to me is, I would say, less than 1% for colorectal mets. I think by the time the patient comes to me from the oncologist for a colorectal mets, I think we have to pay for the sort procedure. They are financially drained. But it works very well. Solitary, I would go in for an ablation if size fits very clearly. If it's a single met,
The same criteria.
same criteria. Exactly. So RF microwave ablation, we follow the same criteria. And if you have multiple lesions and refractory to chemotherapy and the new therapies which are there, you can use CERT very well in it. It does work. In fact, a lot of us are trying to tell them that you start your chemotherapy, not a first line therapy, but if it's not, your first line is not working, use this as one of the options which you have, and then start off with your multitude of drugs which you give for colorectal metastasis.
So tear and cholangiocarcinoma. We've always had large lesions where we always struggle, sir. And then there is plethora of drugs which we use, durvalumab plus
So again, there is no study on tear, a long-term study on randomized trial of tear with cholangiocarcinoma, but it works. In certain cases, it works. Again, the same thing. Advantages of tear in certain cases of cholangio is that you, as I said, you do the planning. If there is a good pickup of the technetium in the lesion, you know that at least the radiation is going to go there and radiate. So it does work. In selective cases, it does work. So your planning has to be very important.
Only reason to ask you is because many times we think it is HCC.
And it's a cholangio mixed picture.
So mixed picture, sir.
So they do work. It does work. So it's basically doing an SBRT. The principle is the same. Your SBRT is external radiation, and here we're giving internal radiation. It's a little more safer. That's all, internal.
Sir, last question. What's your experience about sir, splenic artery embolization in portal hypertension and thrombocytopenia? And second,
so the jury is out on that. I think we used to do quite a few when I was in KEM, or splenic artery embolizations. Now we're doing very, very few.
Because we find it pretty messy.
Yeah, and
subsequent symptoms that the patient.
I have seen surgeons telling me that post partial splenic embolization, the patients are not doing well when they go for splenectomy. But I have seen certain results, but yes, the problem is it works. I feel it works for a short time only. It doesn't long term. I think you may have.
I really am not convinced. I've not, in 50 years of hepatology, I've never been in a situation to recommend that. And I think it's more in the head of the doctor than in the belly of the.
So probably the last
spleen, the very low platelets and.
Yeah, so
last 2 years, I don't think I've done a single splenic artery prophylactic embolization. I mean, what I mean is elective embolization. Yes, splenic artery for pseudoaneurysm, all the different thing, but not done. And I don't think it works.
So problem is, I think probably we used to do it more for those pancytopenias and all, but now we become comfortable with even a 10,000 platelet count, so we are not recommending. We're like, okay, the patient is not going to bleed per se.
Yeah. I am not done. I have not done for the last 2-3 years. I have not done a splenic. And in fact, I've been someone did refer. I said no. Simple. I don't think it works.
and sir,
It's not without complications.
It's got quite a few complications. Infection, severe pain, abscess formations. It can be a terrible thing. And we had one patient, I remember, had to go in for a splenectomy because it caused a bad abscess post. And then the surgeon told me, my God, it was a messy surgery. I said, okay, fine, we'll stop doing it.
sir, down the line, 5 years, 7 years, into toxicity, transplant might start, but how the training of the IR people will be availability? Like, there are very few people like you to train.
You know, honestly, if you asked this question to me 20 years back, maybe we were only 10 or 12 of us in the entire country who was doing our work. But now there are quite a few good people. And I think they are coming more and more to the peripheries also. My only grouse with my IR should not be taken out here. The training program is too short, in my opinion. It should be a little longer. So that's the only thing. But you are getting people. There is an availability. At least as an emergency, there is a good availability. And again, IRs, I don't know of the newer gen, but at least few of us I think we spend more time talking to each other than we talk to our own family. So like Mihir and I think we have, I think if you see my favorite calls will be Akash, Mihir, Rudul, Amit. This is how things are going on right now. My wife's name is not there only.
Same here.
So I think we'll.
So it's basically, I'm telling you, first time I'm meeting Dominic face to face properly, but otherwise I know how he looks because I've interact with him also on Zoom.
Every week we have meetings.
Nearly at 10 p.m.
At 10 p.m. Indian time.
Don't tell me you're like Narayan Murthy.
No, ma'am. So I was trying to get out of this 7:30 session. I'll be very frank with you.
So actually,
I don't agree with you.
we were almost
I
like
don't.
whether we should conducting this session or not.
I was telling Mridul, I called up Akash last night at 8:30. I said, Akash, can we really, do we have to come at 7:30 on a Sunday?
I would say I have really enjoyed this 1 hour session. I hope you all will agree.
Yeah, it was good
I
fun.
learned
actually.
more in this last 1 hour than probably in an entire day yesterday. So I think we'll just
Thank you so much. Thank you.
Sir's question is, don't keep any proceeds on Saturdays and Sundays.
So thank you all for being here. Thank you, Rahul sir. It was quite nice. You made me feel like Karan. You made me feel like Karan Johar on a coffee with Karan. Chalo.
Thank you for coming at 7:30.